welcome all.
Vakratunda Mahakaya Suryakoti Samaprabha Nirvignam Kuru me Deva Sarvakaryeshu Sarvada Sarvakaryeshu Sarvada Sarvakaryeshu Sarvada.
Okay, a very good morning to all. Warm welcome all to the annual CME of Kozhikode Ophthalmic Society, Kozhikode 2020. As you all know, the CME is a debate session with 14 debates. We have here with us a galaxy of great speakers and debaters. Let's welcome all the speakers and the Superman team captains, Dr. Srini Adaklan and Dr. Minu Mathan. And for a fair judgment, we have our honorable judges. Welcome all. For the smooth conducting of a CME, we have two wonderful moderators, Dr. Rajiv Sukumaran and Dr. Fairuz. Warm welcome, sir and ma'am. Above and all, a very warm welcome to our esteemed audience who have joined us on this Sunday morning. And without any ado, let's flag off the program and let the match begin. Thank you all. Now I invite Dr. Sujit, Secretary KOS.
Thank you, ma'am. I'll just go through introduction and for introduction of the program and just briefly about the few rules and regulations we have put up for this program. So once again, welcome you all to the Kozhikode 2020 annual meet of Kozhikode Ophthalmic Society. The program in nutshell, it's a debate competition what we are having today. It's a team competition between two teams. The Raging Bulls versus the Roaring Lions. Raging Bulls is captained by Dr. Srini and the Roaring Lions is captained by Dr. Minu Mathan. There are 14 members in each team, including the captains. This is the entire program. We'll kick off with the 3 debates in the morning session, followed by inauguration, followed by the keynote address, then rest of the 4 debates in the morning. After a brief 1-hour lunch break, we'll start the afternoon session with the keynote address by Dr. Meenakshi and next 7 debates back to back. We welcome all the esteemed panel of judges who have joined us today. The keynote speakers, Dr. Arup and Dr. Meenakshi, and moderators, Dr. Rajiv and Dr. Feroz. This is the one debate session, how it will go. The speaker 1 will talk for 4 minutes. Speaker 2 will talk for 4 minutes. Then we will have the speaker 1 countering for 2 minutes. Then the speaker 2 countering for 2 minutes. Then we will have an audience poll for 1 minute, followed by the summary of the event of the session by the moderator and followed by the judges' remarks. The moderator will give the warning to the speakers. First warning after completing 3 minutes. The second warning 30 seconds before the time. Poll will be open just for 1 minute after the debate ends. The timer will be shown on the screen. So this will be a screen and there's a polling button at the bottom of the screen which you have to click for casting your votes. The criteria for the winning team is maximum number of debate wins. We will announce 2 winners, one by judge's choice and one by the audience poll. The negative markings may please be noted. If the talk extends the time specified, there will be negative markings. The lead status will be announced at regular intervals. The individual debate winner will be announced only at the end of the event. A tiebreaker situation may happen if the judges give marks so that the bull has 7 wins and lions has 7 wins. So on that spot, a tiebreaker question will be announced. There's a disclaimer that most of the questions in the debate are some clinical scenarios that may be which as clinicians we may face in life and cause dilemmas for us in decision making. Most of the situations can have multiple clinical pathways to follow. None of the opinion expressed by the speakers can be taken as final. The viewers should be able to have an independent opinion based on the facts and figures presented here by the speaker and the panelists. We'll start with a short promo video, first by the Lions.
பட் எங்க தலைவனுக்கு என்ன வேணும்னு தெரியும். மஜாப்பா மஜாப்பா இதா 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 ஏய் இடியா வாடா பாத்தி கம்மி ஓகே ஓகே
By the Team Bulls.
मुंबई का बादशाह
क्या चाहिए रे तेरे को?
दुनिया
So we welcome you all to this party, and I hand over the session to our moderator, Dr. Rajiv Sugumaran. Welcome, sir, and he's our scientific committee chairman of KSOs. He's the best person to moderate this. So, to you, sir.
Yes, thank you, Sujit, for that wonderful program you're conducting. Thank you, Vijay Lakshmi, madam. It's a beautiful idea. People enjoy and learn. That's the concept of this program. So as a moderator, I'm here, but if any comments I make, please don't take it personally. It's all in the team spirit. We'll enjoy this program as well as learn. Okay, can I have the first slide, please?
Yes, sir. I'll put up the first slide.
Who's the judge for this first debate?
Laila, madam.
Laila, madam. Madam, Your Honor.
Your Honor.
Your Honor. Yeah, I should address you as Honor.
Thank you.
The first speaker will be Alliance.
Yes, I got it. Okay. Now, this is a very apt topic for this COVID time. During the COVID time, we have so many advantages and disadvantages as far as the surgeries are concerned. So we have taken this topic as bilateral same-day cataract surgery as a COVID pandemic sequelae. And Dr. Ambika Shetty is saying, yes, that's the way to go. Whereas Dr. Soni George is saying it is an opportunistic approach. We want to make the best of the situation. We'll start with Dr. Soni. Okay, come on, Dr. Soni, for the opening batsman.
Thank you, sir. Can I share the screen?
Yes, start. Your timer is up.
A very warm good morning, respected judges, moderators, and a big thanks to KOS. bilateral cataract surgery same day in the COVID, I would say it's a big emphatic no. And before I reason it out, let me tell you the story of a young, dynamic, flamboyant cataract surgeon who suddenly started thinking about making the fast buck. And she also started seeing such shows on TV. And then she decided, okay, 2 at a time. Let me catch both. And then the tiger started jumping. She didn't realize. Then the tiger started turning. And then this is what happened. And little did she know that she's going to give up her team. Now, why do you do cataract surgery one eye at a time? That is quite normal. So this is because there is no great hurry. The patient is always comfortable doing one eye at a time. The surgeon is very comfortable. And for the patient, the other eye is normal. Even if it is a little irritation, he's fine with that. The surgeon can assess the eye, the first eye, and make necessary personalization for the next. Like, for example, there is a refractive surprise, there is a toric rotation. If there is a chance, any complication like an endo for a TAS or a CME, he can always wait and then make the necessary precautions needed for the next eye. And that's why all of us go for that. And look at the normal cases which we go for simultaneous bilateral cataract surgery. The mentally retarded patients, psychiatric patients, infant cataracts, pediatrics, Parkinson's disease, all these, the risk of general anesthesia is more than the risk of having a ocular complication. And tell me how many patients will request you that they want the same day cataract? Very few. Not only very, very, very few. And if at all it's a son or daughter who wants to get rid of this cataract and then go back to work. And mind you, these are the most opportunistic people. The slightest of the problems, they are going to jump on you, sue you, and do everything to make your life miserable. And in the unfortunate event or an endo for a TAS, you're going to have it in both eyes. And however well you treat it, you're going to have subnormal vision. How will you face the patient? And the medical legal issues. The judges are waiting to find a fault with you, and they'll produce umpteen number of studies to show that it is not the way to go. And in COVID time, you want to keep the surgery time to the minimum, 5 to 10 minutes maximum, so that you don't have exposure. And bilateral cataract surgery, however fast you do it, will take at least 25 to 30 minutes. And the RT-PCR does not mean that the patient will not give you the virus. So there is an extreme risk of exposure to the OT staff, to the surgeon, and through him, through the family, and through the society. And this is a crime, doing this. And mind you, this is not the time to do studies and establish yourself as a bilateral cataract surgeon. And God save the souls who try such heroics. And there are umpteen number of studies which very clearly say this is not the way to go. So this is the answer, a complete no-no to bilateral same-day cataract surgery in this era. Thank you very much.
Oh, excellent. You finished very fast and you made it a point very, very clear. Now it's Dr. Ambika Shetty to prove that that is wrong what he said. Come on, we'll see your presentation. Your time starts now.
A warm good morning to all of you. First of all, I would like to thank the Kozhikode Ophthalmic Society for giving me an opportunity to talk today. My topic, bilateral cataract surgery in COVID era. My name is Dr. Ambika, and as I go through the slides, I will tell you why I agree with this topic. The COVID-19, we know the global pandemic, has caused an additional burden for the patients and the hospital. There is an extra cleaning requirement, fear of multiple hospital visits, and also the need for repeat COVID tests. India has the third highest caseload of COVID. When we look at the evolution of cataract surgery, both femtosecond cataract surgery and bilateral cataract surgery are established practices which have developed in the last 2 decades. The presence of the global pandemic has created more surgeons adapting the bilateral cataract surgery. In countries such as Finland, many hospitals perform more than 50% of all cataract surgeries as bilateral. Immediately sequential bilateral cataract surgery is the meticulous sequential cataract surgery on the same patient and on the same day. There is also an option not to proceed with the second eye cataract surgery in case the surgeon faces a problem in the first eye. The prerequisites of immediately sequential bilateral cataract surgery are bilaterally visually significant cataract, Accurate biometry is essential. Skill of the surgeon. The surgeon should be fairly equipped to manage complex cases. Excluding high-risk cases is important. It is important to follow the guidelines that is established by the International Society of Bilateral Cataract Surgeons. Each eye should be treated as a separate surgery and different set of OVDs, antibiotics, IV fluids should be used. The benefits are numerous for the patient and the hospital. The less time is added during surgery, learning from the first eye, faster restoration of stereopsis, fast recovery of BCVA. There is one pre-assessment, a fewer hospital visits, 17% more surgical output, and better health economics. In special situations such as positioning problems, non-cooperative patients like psychiatric and dementia, and anesthetic high risk, there is an added advantage.
3 minutes.
Years, post-operative retinal detachment. This can happen even in unilateral cases which are spaced 1 or 2 weeks apart. IOL power miscalculation is extremely rare with the current techniques. Bilateral endophthalmitis is extremely rare, provided meticulous procedure is followed. Estimated risk of bilateral endophthalmitis is less than 1 in 10 lakhs, but if you compare with the COVID mortality rate, it is 1.7%.
30 seconds.
3 randomized controlled trials between bilateral and unilateral cataract surgery showed no significant difference in the visual function, visual acuity, and the surgical complication rate. To conclude, bilateral cataract surgery in COVID era is safe, provided proper case selection is done, meticulous surgery is followed, and informed decision making is made. There is no need for fiction in medicine, for the facts will beat anything that you fancy. And if Rajnikant can sign with 2 hands,
Yes,
I'm
your
sure
time
more
is
and
up.
more cataract surgeons can
You're going
adapt
to
bilateral
apply
cataract
minus
surgery.
points.
I would
You
like
can
to
count.
thank my
Okay. That was an excellent presentation. Dr. Soni, did you listen to the point she made?
Yes.
She's got substantially good substance in her presentation.
Yeah.
Now, what do you want to say about that?
Yeah, I have to sympathize with her because it's the really wrong time she is venturing into bilateral cataract surgery. All the facts are fine, but let me ask you, exposing yourself in the theater to almost 5 times at least 3 times or 4 times or more time in a theater situation, and exposing yourself to exposing to so many people, including the theater staff, and you compare that with the 1 or 2 post-op visits, which will hardly take 2 minutes, which is more important? And you're talking about COVID death rate. You cannot compare COVID death rate with the chance of an endophthalmitis. And just imagine where are you going to hide if the patient gets bilateral endophthalmitis, which is a very, very, very important thing. And you're dead. If you get that endophthalmitis, you are dead. And if there is a refractive surprise, all these are possibilities. It's not a very, very, very rare possibility. And second, she's saying there is always a chance to skip the other eye surgery. Then in that case, what is the big fun in telling that you're going to do bilateral cataract surgery? If you face a difficulty in one eye, you're not going to proceed with the next. So there is no fun in that. That is not bilateral sequential same-day cataract surgery. And third, she's talking about 17% increase in finances. If you're sued, you're gone. That's all. Okay. One case will be enough to screw you up for the entire case. That 17% finance is not going to support your financial losses or your practice, the loss of your practice. You're dead. You're dead.
Okay, Dr. Ambika, what is that you've got to say about that?
Thank you, Dr. Soni. It was an interesting rebuttal, but definitely the facts don't prove you right. What I would want to say is cataract surgery is the most common surgical procedure performed worldwide, and various innovations in cataract surgery, we know clear corneal incisions, sealing wounds, and foldable IOLs have accelerated the visual rehabilitation process. And in the current era of evidence-based medicine, we have enough data which support that support and favor bilateral cataract surgery. It has been proven worldwide that it's not only the 2 minutes that the patient is coming and sitting in front of you. The patient is sitting in the waiting area.
I'm sorry, your voice is
interacting with all this bilateral cataract surgery. In more than 35,000 cases, reported cases, there have been not a single case of bilateral endophthalmitis, provided the guidelines are followed. So amidst the global pandemic, when the patient presents to the hospital with a bilaterally visually significant
audio is breaking.
if one follows the current...
Okay, you're stopping with that? Or you want to continue? You got time.
Yes.
Say something strong. Come on. Come on. Are you stopped?
I think the facts are all there. It's about we have been no single case of bilateral endophthalmitis. Even if there is endophthalmitis, we are very well equipped to treat those cases and assure the good visual outcome for patients. Definitely, if a patient requests, this should be an option that is offered to the patient.
Thank you. Your time is up. And the topic was exactly bilateral cataract surgery in COVID situation. You're quoting a lot of statistics before that. Now the question is, during COVID time, are you justified in doing bilateral cataract surgery? And according to Dr. Soni, if you do bilateral surgery, the time is exposed to patient, but to get exposed in a theater, you have minimum time for it. It depends on how quick the surgeon is and how quickly he changes from one eye to the other. These points has to be noted by the judge. And I request Judge Madam Laila Madam to come out with your points now.
The poll now.
Okay, that's the procedure.
Madam, unmute madam. Laila madam, unmute
Yes. Done. Allah. Poll is done. Okay, so we have listened to both sides and wonderfully explained by both. Actually, this debate has been going on for the past 5 or more decades, even during the ICC era. And of course, this is an opportunity for the COVID era is an opportunity to reconsider our thought. The debate goes on for the past 5 decades. That itself means we have not come to a final conclusion. So I would like to ask Dr. Ampiga, if given the opportunity and the patient asks you, give me 100% guarantee, will you go ahead with bilateral surgery? Is it not allowed to ask? Yes.
If the patient asks me 100% guarantee for unilateral surgery, even that I don't offer. So yes. Bilateral surgery is out of question. The risks are almost the same for bilateral and unilateral.
So times being very demanding for the patient to ask for 100% guarantee, even with the unilateral cases, and if they are going for bilateral because they are short of time for their job, and then you go ahead with bilateral surgery because you can save some time and some visits. I don't know how far it's going to stand. So the debate goes on. Congratulations, Dr. Soni and Dr. Ambika, for bringing out all the points. And it has been a very good debate, but definitely there is a chance for reconsidering our thoughts for bilateral, where even though not FDA approved, I know that even the topmost surgeon has been doing bilateral cataract surgery in 80% of his cases. Dr. C. Vaishnav recently had a great debate. So I think it is worth reconsidering, not only for COVID era, but definitely worth reconsidering our thoughts. But we have to think of, as Dr. Ambika has already pointed out in her presentation, the three great fears of even infection. The most important, even with all the antibiotic and intracameral antibiotic use, we have not been able to prevent 100% infection, and it has not been possible to bring down the infection rate to less than 0.02. So we have to consider all these things when we think about this. So,
thank you, madam. It was a very good interpretation of the debate. Okay, we'll move on to the second debate, and it's going to be yet another very, very interesting debate. If you look at this, it's a very advanced glaucoma with just a tubular vision there. That too, the upper half of the tube is missing. It's 86-year-old, one-eyed lady with the best corrected vision of 6/60 and a cupping of 0.9 and a cataract of grade 2, small pupil. The risk of surgery is high. And we have the lion, Dr. Meena, to say, yes, I'll do surgical intervention for this. And Dr. Sai, who says we'll do maximum conservative approach. And the best, the maximum medication, with maximum medication, it is, the IOP is still 24. And there is a catch here. The patient is your mother-in-law. I don't know how Dr. Meena has got relationship with her mother-in-law, whether she is going to take advantage of this situation to take revenge or to help her. And Dr. Sai, of course, men have a better relationship with mother-in-law. I don't want to go into the depth of that. We'll go to the debate. I invite Lion Dr. Meena Nair to present her views first. Your time starts in just now.
Thanks to the KOS organizers and to Rajiv.
Slide is not moving.
1 second.
Your time is going.
So thanks to the organizers. And here I am, Lioness Dr. Meena, all set to meet my opponent, the Raging Bull, Dr. Sai Kumar. And I would say, yes, I will intervene in this scenario to give the best of care to my mother-in-law. You know, IOP of 24 on maximal medications, especially when you have a thin cornea, is absolutely unacceptable, especially when you have a 6/60 vision in an 86-year-old. It is a visual disability to live alone. And nuclear sclerosis grade 2 is significant cataract, especially with coexisting glaucoma and a correlating tubular field such as this. Even though the macular threshold program is not there, I would say that the superior field is, there is going to be a fixation threat or a split. So Dr. Sai Kumar, how will conservative management be appropriate in this scenario? If age is a factor, it is not, should not be a deterring factor. It is invalid, and landmark studies have proven that progression is inevitable in this scenario. So my dear friends, surgery is the only option available. Cataract surgery always is complicated by advanced glaucoma. But then look into publications, have a good planning of events, and don't get deterred by a small pupil because you have a variety of pupil expanders which can improve. However, phacoemulsification in this clinical scenario will not reduce the target intraocular pressure. What next? Is it going to be glaucoma filtration surgery? So this dynamic glaucoma surgeon has published in his CK series that zero wipeout phenomenon he has seen. So also all the investigators on the right have substantiated in their retrospective reports that wipeout is rare in advanced glaucoma. What about the literature in India? Look at the KJO, my own colleague and good friend, Dr. Thomas, has published in his series less than 3% wipeout in his surgery patients with a split macular fixation. So in this scenario, losing the existing vision is far worse than the 3 to 5% less than theoretical risk of a wipeout. So in this patient, with this considering age, I would go for a phacotrabeculectomy to help achieve my target intraocular pressure, as well as preserve the visual field and give a good quality of vision to my mother-in-law. You can make a few modifications to the routine phacotrabeculectomy. Bring down the preoperative intraocular pressure with oral carbonic anhydrase inhibitors. Maintain the intraocular pressures with a guarded entry into the anterior chamber and prevent a sudden collapse of the anterior chamber. Use releasable sutures, and with the rule, you have your mother-in-law, you can bring her at your interest to titrate the releasable sutures. And option of mitomycin C is always there. It is optional. I would not use to prevent hypotonic maculopathy because that's one of the greatest risk factors for vision loss. We have literature-based support to say that combined phaco does not cause extra harm to the endothelium. So age is not a limiting factor. So whoever the winner may be, I would say, my dear friends, go for surgery, give the best of care to your patients, consider every patient as mother-in-law. Surgery should not be withheld when IOP cannot be maintained medically. Thank you.
That was an excellent presentation. Consider every patient as mother-in-law. That statement only is little worrying. You to take revenge or what? Or to help her. So we'll move on to the bull, Dr. Sai. Yes, your time starts now.
Thank you so much, Kozhikode Ophthalmic Society. Thank you, Dr. Rajiv, for the nice words of introduction. Let me first of all say two major objections to what Dr. Meena said. Meena is a very close friend of mine and probably one of the most known medical glaucoma specialists in the country who doesn't operate. So all these, aggressive surgical intervention, probably she has to depend on someone. And what I wanted to point out regarding the mother-in-law point, Rajiv has already told. Jokes apart, Meena has a very good relationship with her mother-in-law who incidentally lives in Cochin. Now, why not aggressive surgery? Now, what are you thinking of? You're probably looking at a trab alone. You're looking at a trab with phaco, or you're looking at a tube shunt. These are the options that one has. We all know that there is a high rate of failure of trabeculectomies in these particular patients. With ocular surface inflammation, we have been told that this patient is on long-term medications. And then obviously the high rate of complications. You have the thin cystic blebs that you can see in such patients. You have shallow anterior chambers which can lead to corneal endothelial damage. And you know what is the corneal endothelial count is going to be in these sort of patients. So this is exactly why I wouldn't rush into surgery and I would take a conservative approach. And whatever literature Meena quotes, the chance for wipeout is always there. A one-eyed lady living alone. And, even if it's your mother-in-law, I think you shouldn't do this crime on her. So my approach in this particular patient would be to check compliance. It has been very clearly told that this patient is living alone. Check whether she's applying the drugs properly. And even if you appoint a person just for that, I think it is worth it, and check for the compliance. We have 3 laser modalities which can be used to first see whether the pressure is getting controlled. It has not been mentioned in this presentation whether the chamber is shallow. If so, I would definitely go for a YAG PI. We have the SLT or the MLT, which can bring down the pressure by a few millimeters of mercury in this particular case to bring it less than 20. And we also have the micropulse diode, which has come into the picture recently, which is definitely going to do a lot of good for this patient. And finally, cataract surgery alone, I think, is a definitely good option. With my experience, I'm sure I can give her excellent visual recovery from her 660, maybe even 618 or 624 will do a lot of good for this particular patient. And always think of some last line medications like Ripasudil, even pilocarpine in some patients would definitely help. So the final word from my side is that I would definitely go very slow in a very conservative approach in this case. Even if it is my mother-in-law, even if you don't like her, I would go very, very slow. And this is my approach in this particular patient. Thank you so much for your patience here.
You finished it in just 3 minutes. That's excellent. And you made your points very clear. Just a minute. Let me make a little points here. See, you made it, the point says that with maximum medication, it is 24 still. Still, will you continue, Dr. Sai, with your medications?
Yeah. I mean, that's what I told about compliance. Now, the issue of compliance, as we all know, is a very big issue. And when you talk about an elderly lady who is staying alone, who is one-eyed, you really don't know whether she's properly applying the medication, whether the medication is actually going into her eye. These are things which we definitely don't know. And that is why I am very, very particular to look at compliance in this patient, and maybe even appoint a home nurse or someone to look into compliance. And I'm sure
we'll go to Dr. Meena for our review. Yeah. Go ahead, Dr. Meena.
Thank you, Dr. Rajiv. Yeah, I appreciate Dr. Sai, who's my good friend, who has exposed that I'm not operating. But I tell you, it's not that whether you are operating and you are doing the surgery, you have to give the best of care to your patient and intervene in time. Just because she's your mother-in-law, and like Rajiv said, men probably have a very good rapport with mother-in-laws. I disagree with the statement, because you cannot sleep over, because definitely you know that even if you do a very good surgery, you on cataract alone, this is not going to reduce and reach your target intraocular pressure with the availability of medications, with so much of ocular surface issues cropping up at this age. So I don't think that is possible. Secondly, laser therapy is just a play over and stop over, and you are just going to win time and prove to your mother-in-law that you are handling her well. I'm very sorry. And you have exposed the drawbacks of mitomycin C, but I am referring it to good hands. You know, I work in an institute where I'm really proud that for any type of small pupils, my captain is there, and for him, anything is a joke and play. And also, there's a dynamic glaucoma surgeon with me who has got publications in this direction. So I don't think operating it by yourself is the issue that we are debating on here. And it is the last thing I would ask my good friend to display and expose to get a time over. It is a stopgap. It is a time over, neither laser alone or cataract surgery alone. I'm sure, Dr. Sai, I empathize with you. It is not going to give you the reward of maintaining her field of vision and having her, you may have a quality of vision to some extent for some time, but eventually you will lose the field. What is the use of it? If you love your mother-in-law, you have to go the accepted path. You have to take the accepted path.
Okay, thank you so much. That was very strongly worded statement. It was. Dr. Sai, you have to react. You have to react. There's no other go.
There is actually very, very few points that Meena is saying. She has been going very aggressive because this particular topic has been given to her. Now, nobody is going to jump into the moment you see this patient. Absolutely no one is going, even the most dynamic captain, glaucoma surgeon she is claiming to have in her team. I'm sure even he is not going to jump into this and operate immediately the next day and do that. There is a way of handling these patients. There is a methodical way of doing things here. Check for compliance. Try whatever temporizing procedures you can. She's 85. Of course, she may live another 5 years or 6 years. But the basic teaching in glaucoma itself is that as you get older, you become less and less aggressive. That is proven in all the studies. So from the practical standpoint, I wouldn't jump into surgery in this particular patient. I would go slow, try all the other things in my armamentarium before I go in for a trabeculectomy. And whatever you say, even if you have, just like we spoke about endophthalmitis in the last case, even if you have 1 in 100 wipeout, that particular patient and that particular phase will never, go out from your memory in your lifetime. So I am definitely with the conservative management, and I'm sure most of the people watching it would also agree with me.
the timer. We'll move on. And both of them made their points very clear, and it's a very debatable topic, doing surgery. Let's see what the judge, Dr. Radha Ramanan, got to say about this. Over to you, sir.
Good morning, and really a debatable issue only. Actually, both of you have presented very well. When it is an 80+ patient, if it is one-eyed and clear vision is required, but you have the risk also. Again, the other eye vision also is important. So both sides has got their own arguments, and the arguments will continue like this for years and years. But definitely one factor I think we have to consider is not one factor, actually two factors. One is about surgeon, how much he is confident about his surgery. So every time we will be considering about studies. Practically what you are going to do, that is very important. So whether you have experience in that thing and you are confident. And second thing is whether even if you are confident, your patient has to agree. So this is a very tough situation. Any debatable issue, the very, very important thing, we have to tell every consequence. I think we have to record these both their views, and it should be given to the patient. And finally, it is not the judge, definitely is the patient. So we have to explain to the patient. So that is a very important point. And the rate of progression. Suppose 86-year-old or whatever, so even if it is 60, the rate of progression is very important. If the rate of progression is very slow, I will agree with the Sai, because this is, if it is the other way, I will agree with Meena. So both of them has got their own points. So other eye vision, everything is important. So very importantly, we have to explain this thing to the patient, and best luck to both of you.
Thank you, sir. Thank you, sir. Well, this is the third debate. This is regarding cross-linking of the cornea. A 28-year-old female almost lost one eye because of keratoconus. The other eye is subclinical keratoconus. Will you go in for cross-linking? Dr. Prashov is saying yes, and Dr. Shaji Hussain is saying no. Okay, now we have a judge for this, and that is none other than our Dr. Sasram Sir, the director of RIO, to do. I invite Dr. Prashov for his presentation, and your time starts now.
Respected judges, my learned opponent, and dear friend. This scenario has already been explained by the moderator. I will go for collagen cross-linking in the fellow eye of this patient straight away. Why? Because I think this is a ticking time bomb, and in no time, this topography can turn into something ominous as this. Because keratoconus is essentially a progressive condition. To understand keratoconus better, you have to understand the natural history of the disease. We all know that the keratoconus tends to progress in younger patients, right? But what is young? This is one of the largest studies conducted on the natural history of keratoconus, called the Collaborative Longitudinal Evaluation of Keratoconus Study, the CLEC study, in which patients aged younger than 35 years were found to progress 3 times more than patients who were aged 35 years or more as far as keratoconus is concerned. And also the 8-year incidence of penetrating keratoplasty was higher among patients less than 40 years old of age compared to the patients aged older. And there is a study on the prognostic factors for progression of keratoconus, which has clearly shown that a patient has 4.5 times the usual risk of penetrating keratoplasty in the other eye after a PK has been received in one eye. Now we know that marriage is neither a necessary nor sufficient condition for pregnancy to occur, but in our country, due to various reasons, usually pregnancy follows marriage. And several studies have proven that cornea contains estrogen receptors. And pregnancy is a condition where hormones like estrogen and relaxin are upregulated. This can act on these receptors and can produce biomechanical weakening of the cornea, which can lead to ectasia. It is also known that obstetricians ask pregnant women to lie on the left lateral position, especially in 3rd trimester, where rubbing of eyes against the pillow can also produce progression. Now, there are several studies which have attested to this fact. Now, there are several case reports of pregnancy-induced progression of keratoconus, including one study which showed that in pregnancy, keratoconus progression occurred regardless of whether there was any accompanying disease like allergy or not. And in this case control study, 100% of patients in the pregnancy group experienced progression compared to 0% of the controls. So if there is progression, you may think that you can do cross-linking only after you get evidence of progression. But there's a problem. You need close follow-up, which requires time, effort, and money, which may be difficult. Also, in pregnancy, you cannot perform collagen cross-linking as FDA has recommended against it, and also the drugs that you give after cross-linking may be are contraindicated in pregnancy. If you don't have a collagen cross-linking machine in your clinic, are you justified in not doing it? No, because the law is pretty clear that acts of omission also constitute medical negligence. Remember, the patient has asked for an option of collagen cross-linking and she does not want to lose vision in the better eye. So, if you don't have it, please refer to someone who has cross-link. Now, I will perform CXL right away in this case because patient is a reasonably young female. The risk of progression is high, and also the patient has specifically asked regarding collagen cross-linking and does not want to lose vision in her good eye. Now, my opponent may have random anecdotes, but the mountain of evidence has sure to crush these anecdotal evidences. I'd like to conclude by saying that stitch in time saves 16. Thank you.
That was very good. Excellent presentation. Shall we move on to Dr. Shaji Usaid? And your time starts now.
Presentation is with the host.
Doctor, give me a minute to play the video.
Advanced keratoconus in her left eye.
Okay, your time
This
starts
is
now.
about a 28-year-old female who's married and is diagnosed to have an advanced keratoconus in her left eye with a vision of 1/60, and she's awaiting keratoplasty in that eye. Well, the point of discussion here is about the right eye, wherein she is diagnosed to have a subclinical keratoconus with a vision she is enjoying is around 6/6 parts, and she has no history of allergy in that eye. She has come to me for an opinion of doing a corneal collagen cross-linkage in her only seeing eye. Being a raging bull, my counter is that I will wait for progress in that eye. So, why do I say so? This is with regard to a lot of review of literatures that have come across, and I have concluded that there are 3 key points on which we decide to do AC3R. Well, the first one is there a vision drop? Is there a deterioration in her visual quality? Is there a topographic evidence? More than all this, we have to document a progress in that eye. Well, so is there a progress in this eye? Let's assess that. Is there a vision drop in this eye? No, the vision is still 6/6. Is there a deterioration in visual quality in that eye? No, there is nothing mentioned about it in the question, so we presume that it is normal. More than all this, is there a documented progress? No. So is there a topographic evidence? Well, there is a very strong topographic evidence suggestive of in the posterior float, anterior float, and the pachymetry, if you look at, you can see that it is thinned down to 453. And the curvatures are also on a higher side, that is around 49 instead of the margin of 44. Well, when you look at this topography, the question in mind is the visual acuity still 6/6? I would like to confirm that. Is the patient enjoying a good visual acuity or quality? Well, I would like to discuss with that patient about that with the patient myself. So, if the vision is normal and there is no deterioration in visual quality and there is no documented progress, in spite of having a strong topographic evidence, I would still wait to do AC3R here. Why? Because this is the only seeing eye. Now, if Prashov wants to counter me asking, why do you want to decrease the visual quality in her only seeing eye? Well, my point to that is, or my counter to that is, I would like to bring your attention to a few articles that's been published recently, Prashov. That is in 2019, there has been reported of bilateral keratitis in both eye after doing a C3R. So, C3R is not complication free after all, though it is rare. And also with the recent onset of a lot of newer trends in doing C3R, like accelerated C3R, has definitely increased the complications recently. And I would also like to bring your attention to an article in 2011, wherein he has mentioned all the different complications you can see after doing a C3R, like postoperative infections, corneal haze, endothelial damages, peripheral sterile infiltrations, herpes reactivation. And you yourself know, Prashov, after doing a C3R, there is definitely a slight decrease in the visual quality. So if the patient is having 6/6 parts, you may get a patient who's having a vision of 6/9 after doing a C3R because of the corneal haze that the patient usually develops. So even in spite of that, the patient will definitely complain of a decrease in her visual quality, at least after doing a C3R. So keeping all that in mind, I would like to get an answer to my question. Is there a documented progress? If the answer is still no, so I would like to review the patient after a month and after 3 months. And then I will take a call on doing a C3R at that point. But if you ask me now, my answer to you, the question is, I will wait for progression in the fellow eye. And with that, I rest my case.
That was fantastic. You finished it in time. And if you look at the thing, the case presented doesn't say about the progression. You don't know what is happening. It is a stationary value which was given. Yes, so, but based on that, you cannot conclude whether to do or not. That is the debate going on now. So if there is progression, you definitely, both of you will go in for it. And if there is no progression also, Prashov is saying, I'll go ahead.
Yes.
Is it that?
Yes.
Yeah. So can I clarify during my rebuttal?
Rebuttal is starting now. You can start. Yes, Prashov.
Yeah. My dear opponent seems to have contradicted himself several times. He is misrepresenting facts to the audience. He first said that vision is 6/6. In fact, the vision was 6/6 parts. You have to understand this is a 28-year-old married female. Now, it is a known fact that most of cases in our country, pregnancy usually occurs after marriage. And if the patient wanted to have a family, keratoconus is definitely likely to progress. That we have many studies proving that fact. And he talked about complications of keratoconus. They can be counted on one hand. Several well-controlled studies are there which prove that the complications of keratoconus are very less. Also, the important fact I'll bring attention to the mind of the audience and the judges is that the condition of the fellow eye, my opponent has not touched upon that at all.
Your voice is breaking, Prashov.
Which prove that the risk of keratoplasty in this eye will be 5 times more if your other eye is awaiting a transplant. So please take that into account when you vote. Also, the judge, please note that the other eye is advanced. You have to take the case as a whole. The other eye is waiting keratoplasty. This eye has lowered quality of vision. It's 6/6 parts. And it's not the quality, the complications that he talked about, like haze, they disappear in about 3 months. They are not at all permanent. They do not cause permanent visual loss at all. She is very concerned about losing vision in that eye. And she has also asked for an option of cross-linking. So I think to deny her that option and to say I'll wait for progression is foolhardy. Cannot do keratoconus, means cross-linking during pregnancy because it is contraindicated. Once the patient becomes pregnant and you have evidence of progression, it will continue till during the postpartum period also, the progression. You won't be able to do anything. You just have to watch the vision go down in front of your eyes.
Your time is up. You make your point very, very clear. And you say it's going to progress. And is there any study which says it's going to progress? 5 times you said. Is there a study there?
Yes, sir.
Okay. Then,
yes, sir. Those are studies which are quoted, well-controlled studies here.
Okay. We'll move on to the next speaker. Yes, that's it. Your rebuttal.
Yeah. I really empathize my opponent here. See, Prashov, one thing you have to know here is the fact that the patient is only married. Pregnancy is something you can discuss with her husband, sort it out. He can wait maybe for a month or 3 months, and the rainy season is already, so I think he can control a bit with that side. And waiting for a month, 3 months is, I don't think is a big wait for him. And close follow-up is what is very important here. You have to ensure that the patient has to come to you every month and ensure the topography is taken. And then we can definitely wait for to see if there is a place. And who said in your talk, you said, I don't have 3R machine in my OT. I definitely have 3 if you want to be precise about. So I can do it anytime I want to. And the age, see, it is come to a closer to the age of 35, which we have already stated in talk. See, the patient is 20, you know, fastness or the phase by which it progresses usually decreases by the age of 28. So what is the point? Why can't we wait for a month or 3 months? And the next thing is, you know the progress in corners. This is definitely going to be a slow progress. If the patient one becomes 12, it may drop to 612 if you wait. It's not going to drop to 660 or counting fingers 1 meters in 3 months time. And see, you talked about a time bomb in your first talk. See, you yourself are taking your time bomb. If there is some complication, the patient may end up. Keratoplasty, yes, if it is done by even if it's done by a very good surgeon, you know there is chances of a rejection here as well. And I'm pretty sure that you're thinking about money that is going to come in when you do a C3R, because in COVID time, the hospital will be in a big loss. So at this point, I would definitely want to wait here and ensure that my patient gets a very good thing. And I really empathize your counter. It was an excellent rebuttal from your side. But my friend, here we are in the current era of evidence-based medicine. So we need facts to support our data, and then go ahead with surgeries. Because later on, if the patient is planning to sue you, he will sue you for being blind in both his eyes or her eyes.
Yes,
that's all.
Your time is up, and you countered very well. And both of you have equal number of points, I suppose, with strong points with in favor and against. We'll go on for the audience poll before we go to the judge. And this is the debate number 3. I request the audience to poll. Your poll time starts now. Polling for debate number 3. Now we can move on to the judge, Dr. Sasaraman sir, for your expert opinion.
Okay, a very good morning to all of you. Both the lion as well as the bull, they have put across their points based on scientific facts. Knowing them personally, I thought that would be a very ferocious lion against a wild bull. So, because usually in some debates, so a very ferocious wild fight happens. But surprisingly, both of them have stuck to the scientific facts alone. So because actually it was not what I expected of both these people being a debate. And I think cross-linking is by as far as relatively safe procedure, a very low complication rate. But as all of us know, in any procedure, any surgical procedure, whatever be the minimal risk rate, there is a component of risk. So a 1/8 patient. Even if we have to decide on even a minimally invasive procedure, probably so. Then again, Shaji was also the opinion that he will recheck. He will see after 1 month, probably after 3 months. And even when Prahub says I will go for surgery immediately, I think he didn't mean that he will take up on October 12th. So probably he will also evaluate. Probably he will also decide. So Shaji also said, I will also take up. So there was going with their words. I think there was even a consensus in what they said. So they both of them brought in points to their favor, but literature says both. So I think both of them made good their points. The point of debate which they had to do, they did it extremely well. And the disclaimer what Sujit was saying first, because these are opinions, and whoever takes the decision for an individual patient, as ophthalmologists, when we take an individual patient's decision, it's not what goes by what the lion said or what the bull said. It's by scientific opinion that we grasp from the available scientific evidence as well as debates like this. So that's what I have to say regarding this, and I wish you all well.
Thank you, sir. Thank you very much.
I request Vijayalakshmi Madam to give the welcome address.
A very good morning to everyone on this beautiful Sunday. Respected teachers, senior members, and dear friends. It gives me immense pleasure to welcome you all to the annual CME of Kozhikode Ophthalmic Society, Kozhikode 2020, the Raging Debate. First of all, let's welcome our chief guest, Dr. Meena Chakravarti, President, KSOS, to our CME. Madam is here to inaugurate our CME amidst the busy Drishti preparation. Welcome, ma'am. Next, let us welcome Dr. Raji Sukumaran, Chairman, Scientific Committee, KSOS, who has consented to moderate our session. And as you all know, sir, is very much occupied with the Drishti digital platform preparation. Welcome, sir, and thank you for all the encouraging words and advice. Hearty welcome to our Honorable General Secretary, KSOS, Dr. Mahesh G, to our CME, who has also joined as a debater in our raging debate. Welcome, Dr. Mahesh. Next, the stars of the day, our dear group captains, Dr. Minu Mathan and Dr. Srini Adaklam. Let's welcome them with a good round of applause. Without their support, team spirit, and group trolls, this CME would not have been so enjoyable and possible. Next, warm welcome to all the group members, the Bulls and the Lions, to the raging debate. And let's welcome the esteemed panel of honorable judges. A warm welcome to all sirs and madams. To deliver the keynote address in the morning session, we have here Dr. Arup Chakravarti, Senior Consultant and Director, Chakravarti Eye Care Center, Trivandrum. Welcome, sir. And all participants, please stay tuned to hear the wonderful talk. We have yet another very interesting keynote address in the afternoon session. And to deliver this, Dr. Meenakshi Swaminathan ma'am is here. She was the Director, Academics of Shankar Nethralaya, Chennai. Welcome, madam. Let me welcome another academician, Dr. Fairuz, Founder, Director of the Oral Specialty Eye Care, Bangalore, to moderate our session. Welcome, ma'am. Last but not the least, let me extend my warm welcome to everyone who has made it a point to log in for our CME. Welcome all once again and enjoy the raging debate. Thank you.
Thank you, Dr. Vijayalakshmi, President KOS. Now I invite our President KSOS, Dr. Meena Chakravarti, Madam, to do her felicitation and inaugurate the CME.
Respected dignitaries on this virtual dais, my dear friends and colleagues, it gives me great pleasure to be part of the inaugural function of Kozhikode, the wonderful debate session organized by the Kozhikode Ophthalmic Club. We look forward to listening to an exciting and informative session where the raging bulls and the roaring lions will fight against each other. To me, a debate is probably one of the best ways of emphasizing a point, and in addition to keeping it strictly academic and scientific, it is even more enjoyable. It can be laced up or spiced up with a bit of humor, which is enjoyable, a bit of leg pulling to carry the point forward. I wish the Kozhikode Ophthalmic Society's debate meeting all success. From the KSOS front, we have started the countdown for Drishti. We look forward to a wonderful virtual program, which has about 100 programs, 60 hours of academic session laced with fun. And I would like to thank Dr. Rajiv Sukumaran for taking on his shoulders a tremendous responsibility. All of us are there to support him. We look forward to a very good meeting. My presidential program of NCD 1 month awareness campaign is over, but we are still continuing it. And the Tamil Nadu Ophthalmic Club has taken a cue from us and probably carried forward in the state also. With these few words, I would like to declare the meeting as inaugurated, and I request Dr. Sujit to start the lamp lighting ceremony, the first of its kind. Thank you very much. It's my pleasure to declare the meeting as inaugurated, and I also wish the organizers a grand success. Thank you very much.
Thank you very much, Dr. Meena Chakraborty, madam. First of all, thanking you for spending time with us today and inaugurating the function in spite of your busy schedule. Thank you very much. Let me call upon Dr. Rajiv Sugmaran, sir, who is our scientific committee chairman, for a short felicitation, and I request him to release our KOS has put up a preferred practice pattern for our members. So Dr. Rajiv Sugmaran, as scientific committee chairman, will be releasing the PPP virtually on this platform.
Will you
Rajiv,
play
sir?
that?
Let me play it first, sir.
No.
You can
when
talk.
I come to, okay. Good morning, everybody. It was a wonderful program. Thank you, Dr. Vijayalakshmi, madam, and Dr. Sujit for arranging such a beautiful program with all the debaters in it and the judges. It was a fantastic program. I congratulate them for organizing such a different program. It was very enjoyable. And I'm very happy that they are coming out with a book on preferred practice pattern. Actually, KSOs was actually planning for one because this time it was digital. We couldn't do it and we are planning it for the next year. But if Kozhikode Ophthalmic Club permits, society permits, we can have a digital form which can be displayed in the Drishti website itself so that people can download and read. It will be of very great help. With your permission, I think it will be possible. Shall I release that book now?
I will upload the files.
And that's the book you're going to get. And it is a fantastic book. It's a table-based, easy guidelines for treatment pattern. And I congratulate Kozhikode Ophthalmic Society for bringing out such a book. And I release this book for the, all the members of KSOS. Thank you so much, Dr. Sujit and Dr. Vijayalakshmi, ma'am.
Thank you, sir. Thank you for releasing our PPP. Next, I invite Dr. Mahesh, our General Secretary of KSOS, for his felicitation, and he will be releasing a membership directory which has been put up by the KOS for the members of the KOS. Dr. Mahesh, can I invite you?
Thank you, Dr. Sujit. Respected Dr. Meena Chakraborty, our President, office bearers of Kozhikode Ophthalmic Club, dignitaries, and contestants. It gives me immense pleasure to be part of this program on behalf of KSOS, and I appreciate the work done by Kozhikode Ophthalmic Society in the last few months. They have been very active in conducting webinars with the current office bearers, and it is I appreciate that they have brought out a very useful preferred practice pattern, which if they are willing, we can put in KSOS website and other areas so that it is of use to every person in Kerala. Now, my duty is to release a address book. This also has been a very dream of KSOS to have the full address book of our members, because it is getting updated every now and then. And like Kozhikode Ophthalmic Society, if everyone has to do this, it is very easy for a state society to bring out a massive updated address book. So I congratulate Kozhikode Ophthalmic Society and declare the release of this book officially. You can play the video.
Sujit, unmute. Sujit, unmute.
Thank you, Mahesh sir, for releasing our address book. And I thank all the cases, office bearers for being present today and helping us with the release of our various books, and especially the preferred practice pattern. This was based on the few meetings which we conducted during our last 1 year webinars. We collected it and put it as PPP. That's why we put it as part 1. Probably we'll have to continue it in the next coming year also. Now, let me welcome our Scientific Committee member, KOS Scientific Committee member, Dr. Suma Unnikrishnan, Additional Professor, Medical College, Kozhikode, to deliver the vote of thanks on behalf of KOS. Madam.
Respected President KSOS, Dr. Meena Chakravarti, Secretary Dr. Mahesh Ji, Scientific Committee Chairman Dr. Rajiv Sudharan, other dignitaries, friends and colleagues. Very good morning to one and all. Today, October 11th, 2020 has become a memorable day for Kozhikode Ophthalmic Society. Now, it's my privilege to give away the vote of thanks. First of all, I express my sincere gratitude to Meena Madam, our dynamic president, for inaugurating this CME. On behalf of Kozhikode Ophthalmic Society and my own personal behalf, I thank you, Madam, for the inaugural address with the encouraging words and blessings. Next, I thank Dr. Mahesh, Secretary KSOS, who is the pillar behind all KSOS activities, for releasing the KSOS member directory. Now, I thank Dr. Rajiv Sudharan for releasing the manual of preferred practice pattern. We have incorporated 2 important topics as keynote address, which will be delivered by 2 distinguished guests and speakers who are stalwarts in their respective fields, Dr. Arup Chakravarti and Dr. Meenakshi Sundaram. Thank you so much, Arup sir and Meenakshi madam, for being part of this CME. We are lucky to have 2 efficient moderators for the session, Dr. Rajiv and Dr. Fairoz. I thank them for their spirit and the willingness to accept the task of and efforts of moderating the session. I thank all the esteemed judges in the panel for these 14 debates, who are our own KSOS senior members with vast experiences for making the sessions lively. And this unique CME would not be possible without the team captains Dr. Minu Mathan and Dr. Srini Edeklon and the debaters in each team. Thank you all for taking up the challenge. We are yet to witness the real fireworks of this Kozhikode Bureau. A lot of efforts and homework have been put in by Dr. Sujit and Dr. Vijayalakshmi, Secretary and President of KOS, supported by the Scientific Committee members. A big thanks to all of you from the bottom of my heart. Next, I thank all the viewers of Ophthalmic Fraternity and postgraduates who have joined this virtual CME. Now, I express our sincere thanks to Ms. Krishna and her team from Omnicuris for providing the virtual platform and their technical support. Hope I have not left out anyone. And then finally, let me conclude by once again extending my gratitude to each and everyone on and off the virtual platform. And so you enjoy this day, the experience of learning with fun. Jai Hind, Jai KSOS and Jai KOS.
Thank you very much. Thank you very much, madam, for delivering the vote of thanks on behalf of KOS.
Now we have a very interesting debate, the debate number 4 between Dr. Gopal and Dr. Ashok. It's going to be whether you will give anti-VEGF or a minimal CME of 376 and the visual acuity is 6.9. And the lion, Gopal, great debater, is here. We'll see what he wants to say. Okay, Gopal.
Okay, so thank you very much, sir. This is a 52-year-old man with diabetic macular edema, diabetes and hypertension for him, about 370 at the center. The best corrected vision is 6/9. He is one-eyed and stroke started about six months back. 52 means he's a young patient. He's at the highest notch of his career with economic responsibility, and he has to go 30 more years with all his complications, with stroke, already lost the other eye. We cannot afford to lose even 1% of vision. If we lost one eye in a diabetic, it is almost always due to PDR. And if one eye is lost to PDR, chance of the other eye having PDR and losing vision is fairly high, which data is not given here. Diabetic macular edema with nearly 400 microns at about 52 years is quite early and severe, and vision dropped to 6/9 means that his vision is affected. His reading vision is affected. At 52 years, he's challenged with a severe disease. Now let us look at his systemic conditions: diabetes, hypertension, stroke, lost the other eye, this eye losing vision, young age, probably on double antiplatelets. Let us look at pure science only. So the guiding principles of modern medicine is not treating the symptoms. It is treating the problems. Catching the bull by its horns and managing the bull is the treatment, and not managing the symptoms like visual acuity. We should prevent loss of vision for this patient, and maximum improvement in the present condition should be sought with minimal side effects. That is a bioethical challenge. Causes of decrease of vision in this patient could be progression of DME, progression of PDR. More critical data here is the background DR status, which is very important. I want to take it at this point that many people take OCT and treat the OCT, but no, you have to treat the background diabetic retinopathy. Our Dr. Arup Chakrabarti, our keynote speaker, talked about 6/6 vision and quality of life. Here is a patient with 50 years old who has significant quality of life problems with mild visual acuity loss. And this shows that the quality of life improves rapidly during the first 3 months of injections in any patient with diabetic macular edema. He's a one-eyed patient with diabetic macular edema with loss of central vision. Younger people, like this is 35 and this is 50, are lost to follow-up more because they have a lot of other problems. And in this case, hypertension accelerates progression of diabetic retinopathy. One eye is lost due to PDR, means other eye chances of bleed or surgical PDR developing is about 50% in 2 years. Even diagnosis of PDR in one eye, about 40% develop PDR in the second eye in 2 years. Chances of vision loss in PDR prevented by the anti-VEGF injection. Anti-VEGF reverses the background DR status in about large percentage of groups. This is the protocol as data with PDR as well as CSME, where there's a significant improvement in visual acuity to 8 letters by about the 4th injection. Here we require only 5 letters of improvement to reach 6/6. 250 microns was the cutoff of CMT in almost all the DRCR trials. We have 6/9 or lower vision and 300 microns or more thickness. That is all the trials, and we have that criteria fulfilled. What is protocol V? What is good visual acuity? Protocol V is about good visual acuity and how you should treat or not. 20/25 was considered the best visual acuity. If it falls below 20/25, then they took him the patient for injection. Our patient's visual acuity is 20/30 and he is one-eyed. This is the safety data, the RISE, the RIDE, the RESTORE, the RESOLVE. All these data showed that the safety was all right in the 0.5 milligram dosage. Doctor's philosophy should not be imposed on patient needs. Nothing to be done now is equated to be nothing can be done. Why don't we offer the best possible treatment, clinical trial treatment to this patient? Compliance, cost, burden, all these are fulfilled here. Now, let us look at the pure science. Visual criteria, OCT criteria, one-eyed status, quality of life. You've done it all. We have to individualize, not generalize. Why aren't we giving him the best possible care is the only question. Thank you very much.
Excellent. Exactly 4 minutes. And let me invite the judge for this session, Dr. Giridhar sir. Sir, welcome to this program. And that was an excellent presentation. Shall we move on to the next speaker, Dr. Ashok, the bull?
Yes.
Your time starts now.
Yes. The treatment for central involving diabetic macular edema, as Gopal said, is intravitreal injection. But certain situations here doesn't warrant injection. As Gopal said, we have to individualize treatment in this patient. Gopal said this is a very young patient. This is not a young patient. This is a 52-year-old patient, middle-aged patient who is at the risk of stroke. The current evidence for giving intravitreal injection for central involving macular edema, the visual criteria is vision should be less than 6/9. Whatever Gopal said doesn't apply in this scenario. Then we have something called protocol V. In protocol V, what is said that patients with good vision. Gopal again said it is not applicable to this group. It is applicable only to patients whose vision is better than 20/25. But what about that gray area between 20/25 and 20/30? I think in this particular patient with a history of stroke and other risk factors, we should err in the favor of safety. And with this current data, it says that observation is also a good option in these patients. In 2 years, if you observe these patients, their vision is maintained at this particular level in majority of the patients. They don't require treatment. Once you start treatment, what happens? You have to give them multiple injections. Again, treatment burden increases. The cost of treatment also increases. And discontinuation of treatment, if you discontinue, everything is going to come back. So that is not going to be the solution at this point of time. The most important thing would be to observe this patient and closely monitor, and always a patient can undergo treatment if there is worsening of symptoms. Then the next point, the patient has had a history of stroke. You should look at the risk-benefit ratio. Risk is more in patients who've already had a thromboembolic episode. This patient already has a thromboembolic episode. And risk increases with multiple injections. See, in diabetic macular edema, you cannot stop with one injection. The patient is going to get more and more injections. And again, his risk of going in for a stroke or, serious cardiac adverse events is going to be more in this particular patient. Then it is a one-night patient, and patient has got relatively good vision, 6/9 vision. There is always a risk of endophthalmitis in these patients when they undergo injections and then they receive multiple injections. He's a diabetic, multiple injections, one night. So what if the patient develops an infection? What is going to happen? He's going to lose vision in his only good eye. So it is like, bull in a china shop. Just to get something, marginal benefits which doesn't have real evidence according to whatever studies we have now. To create more collateral damage means losing the patient, his vision, his life. Now, Gopal also talked about protocol S. Protocol S is for PDR. It doesn't consider diabetic macular edema as such. I feel Gopal has totally tried to confuse the audience with multiple studies, multiple scenarios, which doesn't apply here. So to summarize, a patient, one-night patient with 6/9 vision, lately good visual acuity, existing evidence suggests that it is better to observe, but closely monitor and treat or intervene only if vision worsens. Thank you.
You finished in time, well ahead of the time. See, both of you have come out with very good points in favor and against, and I feel Gopal has to be a little more stronger to contradict him. I invite him for the rebuttal. Gopal?
Yeah, okay, sir. So first of all, he said this patient is not young. A diabetic retinopathy patient, when he loses vision in one eye, it requires at least 20 years to reach there. So he has about 20 years of diabetes. So that is why I said, and still 52 is because that is why I said he's young. A patient with 70 who develops a diabetes and a small problem is not a major problem. Now, stroke 6 months back, all the studies have shown that if there is a thromboembolism, you wait for about 3 months. He's a one-night patient. Now, protocol V, he talked about protocol V is very clear. Clinical trials are not ambiguous. It is not confused. 20/25 or better, you observe. 20/25 or lower, you treat. What is the cost? Have anybody see what is Ashok talking about cost? He's a one-night patient. He's going to lose the other eye. His reading visual acuity is lost. And then if he cannot afford the highest brolucizumab or aflibercept, he can be given at least ordinary anti-VEGF agents. There is a Indian ranibizumab available. Observe. He's talking about observation. Observation for how long? Now he will say 6/12. So then he will say, okay, you are moving around in the house now. Then he will say, okay, you can move from one room to other. See, his visual acuity. See, why has he come to a doctor? Is basically because he has a problem. He has a decrease of vision, and that is why he has come. Thromboembolic events, ecosprin. He is on ecosprin and clopilate now probably, and multiple injections definitely. Between 52 years and 80 years, he will require multiple injections. One-eyed, yes, he is one-eyed, and that is why we should treat him. And protocol S, there is no confusion. Protocol S, I said, in protocol S, in the subgroup with PDR with CSME is the group which I said. So absolutely there is no confusion. He is confused so that he is not even able to bring out a slides. Thank you very much.
Oh, that is fantastic. Ashok, you are confused, it seems. What do you want to say? Your rebuttal now. Your time starts now.
Yes, as Dr. Gopal said, the patient has come to a doctor to get optimum treatment, and it is not to get over treatment. What we are talking about is it is not about not treating. It is about risk-benefit ratio. What will happen if you observe? You have to closely monitor the patient. If vision goes down, if there is a tendency for the vision to go down, you can always explain the risk and benefit and always treat at a point of time when you feel the vision is threatened. See, as Gopal said, this ambiguous area between 6'9" and 6'12", this group, it can go either side. You can always say you can observe. You can always say you can treat. That doesn't mean that you can always, you need to always treat the patient. Now we were talking about the other eye. The other eye, we don't know how the patient lost vision. It may not be due to diabetic retinopathy at all. So that doesn't hold here. And protocol S is basically about PDR. It is not about diabetic macular edema. I reviewed that argument because there are 100 studies about diabetic macular edema only, and talking about protocol S and saying that that is a major study on diabetic macular edema, I fully disagree. And I feel, if you have very good clarity about a subject, you don't need slides like Gopal has shown in this particular presentation. So I would say to closely observe and monitor the patient. And if at all there is some problem with vision, you can always intervene. And to intervene means patient has to get multiple injections. And it is very clearly shown that patients with history of thromboembolic events, they have risk of stroke with multiple injections. That's a point I wanted to put forward.
Thank you, Ashok. You made your point very. It looks like that the debate, this particular debate, it's from your heart. What you are really doing. That's very important at this. We'll go in for the audience poll before we go to the judge. And I request the audience to poll for debate number 4. Your time starts now. Yes, time up. And I invite Giridhar sir, the judge for this session, for his expert opinion. Sir, are you there?
Yeah.
Yes.
Can you hear me?
Yes, sir.
Yeah. Anyway, very nice debate, very interesting debate, and I think both the speakers, I think, were very powerful, very assertive, I would say, and I think they have argued the debate extremely well. I thought I'll just say a few points before I just wind up. Basically, number one is the history does not say anything about how much of problem the patient is having. It's only a patient with 6/9 vision. Both the speakers did not in any manner highlight about metabolic status, associated renal disease, etc., which are also very important when you see a patient with very good visual acuity and very mild CSME. Because if you have a mild CSME with a highly uncontrolled diabetes, then probably waiting would be better rather than injecting immediately. So this is another area. Gopal spoke extremely well, very assertive, but Gopal was focused extremely on PDR, a very lot of emphasis on proliferative diabetic retinopathy, then the center involving diabetic macular edema. On the other hand, Ashok was trying to scare the patient with infection, which is a very, very, very rare complication of intravitreal injections. So Gopal was carrying the patient because of proliferative disease and sudden loss of vision, and Natraj was trying to scare the patient with infection as a possible complication. I think these are some of the points, but the most important point I think is that number one is we do not know how symptomatic the patient is. That's very important. When you get a patient with very good visual acuity and a very minimal center involving diabetic macular edema, the question arises as to how symptomatic the patient is. If the patient is very symptomatic, definitely we have to treat. If the patient is not symptomatic and the diabetic status is also questionable, probably waiting for 1 or 2 months, reassessing the metabolic status and managing these patients may be a very good call. in such a situation. So these are some of my points. Then Ashok said, once we start treatment, we will need multiple injections. Even if you don't start treatment, later you'll need multiple injections. So it's not that if you don't treat, you are avoiding injections. You may need injections later. So that also is not a great argument. So nonetheless, both of them have argued extremely well. The debate was very good. There were a lot of take-home points. And as far as RCT trial is concerned, Ashok could have highlighted on the systemic complications of anti-VEGF based on the various RCT trials. It would have been a good information to the audience, because this is one area where we still, although we read about it, we still don't know offhand what are the risk factors for systemic risk factors as far as this is concerned. I agree with Gopal that, once we have a stroke, we can wait for 3 months, but after 3 months, if there is a necessity for injection, we can inject. But my protocol is, even in such a situation, I usually get a physician's clearance or a neurologist clearance before we do that, because that again is very, very important. Nonetheless, good debate. Both of you spoke very well. Ashok has already gone out of the screen. I think he has got another debate probably going on somewhere. So best of luck to both of you, and best of luck to this very interesting program. Thank you for giving me an opportunity.
Thank you, sir. That wonderfully you summarized the debate. So we'll move on to the next debate. Can I have the slide, please? Debate number 5, being judged by Dr. Elizabeth Madam. The debate here is between Dr. Meena CK and Dr. Sanita Satyan. It's on whether to have a multifocal or an extended depth of focal IOL for a traumatic cataract, unilateral traumatic cataract in an 80-year-old child. Previously had 6/6 vision in the eye. So I invite Dr. Meena CK to present in favor of it, and over to you, Dr. Meena.
Okay, so this is debate number 5, and already we have the scenario has been explained that it's an 80-year-old boy who had a 6/6 vision, now has a unilateral traumatic cataract with normal cornea and posterior segments, and parents are keen on cataract surgery with extended depth of focus IOL or multifocal IOLs. Definitely I'll opt for a multifocal. The reason being, you have to give them the best that technology can offer with minimum hassles. And the multifocal, like the trifocals which we have now and the extended depth of focus, they are excellent options for this. Now, from my personal experience, what I have seen is there is a tendency to avoid near vision glasses in children, especially when the other eye is emetropic. This can ultimately lead on to strabismus, which is very common. In this child who is 8 years, that is beyond the amblyopic age, maybe amblyopia may not settle. So why the multifocals? Because you have very good multifocals and extended depth of focus IOLs available now with good technology, and the vision correction happens across multiple distances, and you get good intermediate and near spectacle independence. So this intermediate factor is very important here because of this era of online classes, and also better stereopsis have also been reported following these lenses. Now coming to what is happening with these lenses, so nowadays what the diffractive platform we are having can be explained by this basic experiment of 2-slit experiment. That is, you are having various mirrors on the IOL, and the light waves are working, the light waves works like this constructive and destructive interference. That is the basic thing. So you can focus at different points with such lenses. That is the advantage of these diffractive platform when compared to the refractive platform we had earlier. Now you have to think about the patient factors like the type of cataract the child is having, the capsule management, which is very important in a child, and the pupil status. So here you can see a few sphincter tears, definitely that will be there in traumatic blunt traumas. But the diffractive lenses, the advantage is that most of them are independent of the pupil. But still, if the pupil is quite large, you can go for a segmental pupilloplasty, which is not a difficult task to do, and that can help out. And coming to the type of cataract, here the anterior segment has not been involved. That has been mentioned, like the cornea is also clear. So there's no need for immediate surgery. You can wait for 1 or 1.5 months, and it's not in the amblyopic age group. And blunt trauma usually causes a rosette type of cataract. And you can see a plaque here. And usually, in my experience, what I have seen, it's usually a plaque on the posterior capsule, or you may even have a PC dehiscence. But with 1 to 1.5 months, fibrosis sets in very fast in children, and it's very easy to shape up these fibrous posterior capsule into a very excellent posterior capsulotomy, which gives you a good visual axis clearance and in the bag implantation. So are you worried about the dysphotopic phenomenon? That is one problem with the multifocals. But with the the new advanced multifocals, you have very few reported disturbance in the everyday life. And neural adaptation, mind you, it is phenomenal in children. They can accept very large amounts of anisometropias. In our experience, we have seen that neural adaptation is extremely high in children. And unilaterality, can it cause a problem? And visual performances, we have seen that bilateral and unilateral implanted patients does not have much of a difference. So considering this patient, I favor a multifocal or an extended focus, considering he is an 8-year-old, that is beyond the amblyopic age. He blunt trauma cataract, which behaves well, and the pre-trauma status is emetropia. So thank you.
Thank you. Thank you so much for completing it in the time allotted for you. And she made a point very clear. Over to Dr. Sanita for your presentation. Your time starts now.
8-year-old child with traumatic cataract, I am for monofocal IOL implantation. Why monofocal? Because it has been the standard of care and it is time tested with robust evidence regarding its use. And why not multifocal or EDOF IOLs? The same reasons. The technology is only evolving now, and there is sparse evidence for the use in children and those with traumatic cataracts. So first of all, why do you implant multifocal IOLs in adults? We know it is to counter the loss of accommodation and promise for vision for distance, near and intermediate with spectacle independence in most of the cases. But the fundamental challenge of multifocal technology is that you have different focal lengths and you need to preserve the optical quality at this multiple focal lengths. And when you come to children, it's increasingly difficult because we know biometry is a very important part of multifocal IOL implantation. In children, you usually have corneal scars associated, especially when you have a traumatic cataract also. Precise biometry is a great challenge, and along with sometimes you will have to take biometry under GA with a little bit of manipulation. And pupil size less than 2.5 millimeters may not be there because of iridodialysis or iris injury. And also astigmatism in an 8-year-old boy is always evolving. And intra-op also, you do have a lot of challenges like the integrity of capsule and the centration of intraocular lens. And you may have a large pupil because of iris injury, which may lead to photic phenomena also. We know inflammation after cataract surgery is a very important and very common in children, especially so after trauma. And again, there would be a ubiquitous posterior capsule opacification, which occurs almost in 100% of cases. So again, all these are going to compromise your clarity of your visual axis. Again, with a multifocal IOL in a child, this fails the purpose of an IOL implantation altogether. And long term, we know that these children are likely to have photic phenomena. They have glare, halos, and starburst. And in an 8-year-old boy who is very active, this photic phenomena are going to disturb him. And then neuroadaptation is very difficult. Even in adults, we know that we have to teach the patient to adapt, and the brain has to adapt for proper vision with multifocal IOLs. In children, this is increasingly difficult, and the child may choose not to use the eye rather than neuroadapt. And then you can have amblyopia and loss of minor clarity. So multifocal IOL provides low contrast images for all these distances. When compared to a vision with a cataract, which could be a blurred kind of vision, this is equally or more incapacitating. So a child with multifocal IOL may end up in amblyopia due to less stimulation in the affected eye. And there are a lot of unanswered questions as of now. What about the problems with axial elongation, which is prone in children with IOLs? What about the development of optical aberrations? What about neuroadaptation failure and the development of amblyopia? As of now, the evidence is sparse, then the results of anything you do in a child are going to stand for a lifetime. And so I swear by Hippocrates, I am for monofocal IOL implantation because first, as a physician, I would never like to harm my patient. Thank you.
Okay, that was a fantastic presentation. Both of you did justice to the topic. And the only question is, what type of spectacle do you give for a monofocal IOL? It's to Dr. Sanita. Did you hear that question?
Sanita, please unmute.
Yes, sir.
What type of spectacle do you give?
Okay. We always give a bifocal in children. In 8-year-old child, you can even go for a progressive glass if the child is okay. That's the conventional way of
point I wanted to clarify. Otherwise, both of you had enough points to substantiate your topic. And we'll go for the rebuttal. We'll ask Dr. Meena to counter this. Over to you, Dr. Meena.
Thank you, sir. That question itself, you have asked that. You give bifocals and progressive, and in our experience, what we see, most of the children come back without using glasses because they're comfortable with the other eye. So nothing happens. This eye it may not go for amblyopia, but that binocularity is not there. So whatever Sanita was talking could have been applicable almost 5 or 6 years back. But now you have very good multifocals available. That is from the experiences we have in our adults, we start using in children definitely. And we have seen that what she was talking about, neural adaptation, that is extremely high in children from our experience. Even very high amount of anisometropia they can tolerate with good stereopsis. So that is not applicable here. That is what I feel with my experience. And the organizers have given the slide of the eye. So the anterior chamber was not involved, pupil was not disrupted that much. And already I have talked about management of the posterior capsule. It is better to manage the posterior capsule to give you a clear visual access. There was no point of having a PCO then. So these are the points, and it's an 8-year-old, and it's not that difficult to manage an 8-year-old to get a good biometry. It's not difficult. You don't need a GA. So considering this age and the type of cataract, that is a blunt trauma cataract, which behaves extremely well for your surgery. So all the points I've already mentioned in my presentation. That is my rebuttal. Thank you.
Finished before time. Over to you, Dr. Sanita.
Thank you, sir. Yeah. So Dr. Meena is the person who taught me to do a pediatric cataract surgery, and I respect her. And with due respect, I'm saying a few points. Madam, I appreciate all your points, but there are certain issues which you have by your talk, I thought the audience would have got misled. One, most important is about the neural adaptation. Madam is always talking about neural adaptation in case of an amblyopia, which is okay because we do share the same experience. But when you talk about multifocal IOL, as I have shown in the last slide, multifocals do have a decreased contrast sensitivity and the modular transfer function is much affected. So the neural adaptation, even in a patient, adult patient, as Dr. Aroop's keynote has demonstrated, we always think twice, thrice, or 100 times before offering multifocal. This is exactly due to the same reason of neural adaptation, which in a child is different from that of amblyopia. This is an important point which Madam might have missed. Another thing is Madam has told that she has great reliance on newer generation of diffractive IOLs and EDOF. But I would like to say these are technical advances, but they do not, they have not changed the scenario as a first choice for multifocals, because even in EDOF IOLs, the clarity or the intermediate axis distance vision and near is a little bit better than the conventional bifocals or trifocals, but the problems with decreased contrast do exist. And another point is from 8, Madam has told that she is 8 years old, but amblyopia can occur even up to 12 years or more than that, because we do have experience behind it. And PC dehiscence with a great surgeon as Dr. Meena, I know the pediatric cataract surgery in such a person is not a problem, but surgery is only a small part of this management, and the centration of IOL is going to be a great problem, and most of the children do develop PCO. And Madam has always been quoting her personal experience. I do respect her personal experience. I have worked almost 10 years in close association with her, but we have to, as scientific people, need to rely on evidence more than personal experience. And there is absolutely no evidence for this. Thank you.
Yeah, you can wind up. Madam, Elizabeth, madam, you're there? Your expert opinion, madam.
Right now, after the audience poll, no?
Sorry, after the audience poll. We'll go on for the audience poll. This is for debate number 5. The time starts now.
Argument audience poll.
Yes, time up. Over to you, madam. Elizabeth, madam, for your final judgment and
yes, yes. So the lion has roared and the bull has fought very nicely. But still the controversy is going on. The debate has never ended. So one person is for a time-tested thing and the other person is for the recent thing. I know Dr. Meena, she's a very good surgeon. She's able to do a well-centered, well-placed multifocal IOL. But one problem I would say is that nobody has taken care to find out what is the size of the scotopic pupil, what is the size of the photopic pupil. If the pupil size is small for bright vision and if the pupil is large enough for a distant vision, then I would suggest that a multifocal is good. In that picture, it is not anywhere mentioned what is the photopic size and the scotopic size of the pupil. That is one point I have to make at this point. And otherwise, I am also optimistic about multifocal. We should give the best possible to the child. Best possible, whatever is available, the latest technology. If you're confident, there's no harm in giving it. But the ultimate choice, you have to explain the whole thing to the parents, and the parents have to make a decision. There will be a little bit of decrease in contrast sensitivity, little bit increase in halos if you give a multifocal, and the child is spectacle free. But if the child is ready to wear the spectacle and if the parents are sure that the child will wear spectacle, then you can err on the, or you can opt on the safer side. So what I would say at the end of the session is that the debate still goes on. You have to individualize. You look at the pupil, look at whether there is any sphincter tears. If there is a sphincter tear, and whether there is angle kappa, large angle kappa, this also has to be considered. And if you are very confident, you can go for multifocal if you think that this child wants a spectacle freedom. But in the other hand, if the parents are more conservative, parents do not bother about making the child wear the spectacle, then monofocal also can be done. So it's an individual opinion. Thank you.
Unbiased opinion, madam. Well, that was very nice. We'll move on to the next debate, debate number 6. Charles sir will be judging the debate, and Patmaja madam and John Davis Akra will be the contestants. Can I have the slide, please? It's about tele-refraction. John is always a tech-savvy person. He's excited and futuristic about all this tech-savvy, whereas Madam is the winner of debate and KSOs for past several years. She can do wonders with her talk. Over to you, Madam. The Lion is going to open the innings. Over to you, Madam, for your presentation.
Thank you, Rajiv. It has been my duty this time to start this debate. The rules of the debate mandated that I should speak against before all of us had a chance to hear John speak for it. Usually it's the other way. The affirmative comes first and the negative next. Anyway, I think because John hasn't told you what telerefraction is, I must speak 2 words about telerefraction. To tell you the truth, I had no idea what it was till I started preparing for this debate, and probably that holds for some of you too. Telerefraction, as the name implies, is doing refraction from far away, assessing the refractive error of a patient from a distance. So you are not there with the patient when you assess his refractive error. And I found that there are many players in the market, and they are all use different platforms and different methods, ultimately to objectively assess the refractive error. Why have these come in? Part of the reason is that all of us, ophthalmologists, optometrists, consider refraction both a bore and a chore. At the same time, we are all interested in the multi-billion-dollar spectacle industry. So these apps have been developed in the US. They try to popularize it in the US. As I understand, it's still not very popular, and they're making their claims that it would help in underdeveloped and developing countries. So let me say, why am I against this? The more I read about telerefraction, the more alarmed I became about what it is trying to do. The simplest ones make you stand from a chart at a specified distance, read from the Snellen. So you need a smartphone, which will act as a mouse, and you need the screen, which has the Snellens, and the chart is displayed to you. You have to tell them. It tries to assess astigmatism by showing you an astigmatic fan. And then after assessing the refractive error, the level of vision, it assumes then intuitively that this might be the power that you need. And I'm sure all of you who have been prescribing glasses are well aware of this, that if a patient reads 618, maybe the refractive error is about 1.5 plus or minus. So the simplest one, and this is the one that started it all, called Ophthalmic, which was denied FDA approval and then changed to visibly, and I think even now it's in the courts. Some states have permitted, some ophthalmologists and optometrists, they managed to get on board, but even now it's not very popular. And of course, the other reason is that they are marketing this as telemedicine, which it certainly is not. It is telerefraction, all right. Their only aim is to find out whether you need glasses, and glasses will improve. And they're clever enough to refer where they suspect there could be something wrong to somebody else. So, Rajiv, did you say 3 minutes?
1 minute more, madam.
Okay, fine. So all I'm trying to say is that these are all objective methods, and from time immemorial, we have prescribed glasses subjectively. Never mind how you assessed it. Some of them use autorefractors. None of us, not one of us, even if our subjective refraction tallies with the autorefractor readings, we would never prescribe based on the objective value. And if this is technology of the future, I'm sorry, the time has not yet come for it. And we certainly do not, I repeat, do not need telerefraction. Thank you.
Thank you, madam. You did a wonderful job even without a slide, madam. Over to John, the tech person. We'll see what he wants to say. And your time starts now.
We are the Raging Bulls, and welcome to the Raging Debate. I am speaking for the topic telerefraction. It is exciting and futuristic. Any debate has 6 questions. What, who, when, why, where, and how. Let's look at what is refraction testing. Objective refraction is where you find the refractive error using retinoscope by neutralization technique. And subjective refraction is where you find the glass prescription. Refraction currently is done using the portable retinoscope, the trial lens set, and the Snellen's chart. These are bulky equipment. The process is time consuming, the equipment is expensive, and these lenses are often lost. Let's look at the evolution of refraction. So starting with the single mirror and 2 mirror retinoscopes, we are now at the stage of the portable battery operated retinoscope with the trial lens set, and we also started using the LED vision charts, the autorefraction, and the phoropters. But we can go ahead to telerefraction with smartphone now. that is already here in the year 2020 AC, that is after Corona. It was supposed to be the year of perfect vision, but with Corona we had some setbacks. Telerefraction can be smartphone based, laptop based, virtual reality headset based, or an extra device attached to the smartphone. Let's see the Peak adapter and app. The Peak app is for vision testing and the adapter for fundus photography. It can measure visual acuity using the e-chart. It automatically calibrates the optotype size and brightness using the phone screen information, and we can swipe and shake the smartphone to record the patient response. But this is much more than that. IQ, Vision Check Mini and Insight devices, they can measure the subjective refraction and IPD. You can check your vision at home with refraction and order glasses online. It costs $90, which is 6,570 rupees. Let's see how it works. So on the smartphone screen, these red and green lines are shown, which are looked at with this device. It passes through the optical tube, through the red and green filters and lenses, and the patient adjusts them together with the buttons on the device. This uses a mid-range smartphone display which is above 250 ppi, and most smartphones, even the old iPhone 6s and the old OnePlus 3, have resolution better than that. This gives a 0.25 diopter resolution, which is all that we want, and we can go much higher with these PPIs. Astigmatism also can be measured. But that is not all. Victor Pamplona and Professor Ramesh Raskar from MIT helped to found iNetra, which
1 minute more.
Devices. One is a smartphone-based refraction, which we already saw, and then there is the smartphone-based lens meter and a phoropter. These three devices together, they cost 2.19 lakhs, which is not expensive considering that these are three expensive conventional devices. And these telerefraction devices can be delivered to the patients like an Uber. That is one possibility. That is called the Uberization of eye care. We can also use this inside the clinic itself. For example, during the COVID pandemic, to maintain social distancing, such as this VMAX device can be used as a full-scale refraction and with social distancing. So we saw that telerefraction is safe, affordable, comfortable, convenient, accurate, and portable. Thank you, and don't forget to vote Bulls.
Yes, excellent. Exactly 4 minutes. That was nice presentation. It looked Greek and Latin for me, but we'll have a review by Madam on this. Madam, over to you, Madam.
Okay, I heard what John had to say, and I found the same, that there are some of them which are very simple and can be used at home. Some are which can be used only in an optometrist office. The one thing that he talked about, the iNetra, has a lot of stuff, and I don't understand why they can't have a qualified person along with it to do it. The ones that you do at home are targeting. What I forgot to say is most of these need you to be 18 or over 18 and under 45, 50, depends on the different devices. And all of us know that most refractive errors will stabilize by 18. Many of them ask you for a previous prescription. So if with your previous prescription you read one line less, you know that you need to add about a 0.5 or 0.75. The other thing is that many of these on studies, which have all been sponsored by the companies themselves, are off by half to 1 diopter. So I do not think that people they are targeting are the 20, 40, between 20 and 40, the IT professionals who have money, who don't want to move out, who want to save their time. I don't know for what. But I repeat, I do not think that without a person in front of them, and vision is not all, visual acuity is not all. You always need at least once a comprehensive eye examination, never mind your age. And encouraging people just to change their glasses and say that you do it because it's so simple to do it is not right, it's not fair, it's not unethical. And I think all of us will have to educate our patients that, look, if you are seeing well with your present prescription, go ahead, repeat it without a refraction. And if you're not seeing well, please go and make sure that it's only a refractive change. Don't play doctor for yourself, and don't try to have somebody far away decide for you and sign a prescription without even having see new ones. Thank you. That's all.
Thank you, madam. Exactly 2 minutes. That was very strongly worded statement from madam. What does John got to say for that? What do you, John?
Thank you, madam. I appreciate what madam said, but I think what madam had looked at was all the telerefraction of 2020 BC, that is before Corona. But now 2020 AC, we have much better options than Opternative. Opternative has been discontinued. They changed their name and they have been discontinued. What I am talking about is all the newer ones which actually do a proper refraction with these devices, as I explained how the devices work. And these things are definitely not a replacement for the eye examination. This is only a replacement for the vision testing and the spectacle change. So you are supposed to do vision, an eye examination at some point. But for just refraction, especially for busy IT professionals who really do not have time, and for people who cannot afford to come out into COVID pandemic into the hospitals, this is the best alternative in 2020 AC. And these devices, they are accurate, the newer devices, not Opternative. Opternative is obviously been discontinued, but iNetra and IQ Mini, they are having very good accuracy, and they do a proper subjective refraction and get you the exact value up to 0.25 diopter accuracy.
That is fantastic. That word ACBC, that is something new for this COVID time. We'll go for the audience poll before we go to our judge, Charles sir. And the time starts now. This is for debate number 6. Time starts. Number 6. Time up. We'll request our judge, Charles sir, for his expert opinion about the lion and the bull. Sir, over to you, sir.
Okay, thank you, Rajiv. Am I audible?
Yes, sir.
Dr. Padmaja, with her enviable and eloquent communication skills and vast experience, has done extremely well in supporting conventional refraction, exposing the disadvantages of telerefraction or remote refraction. Whereas I'm very much impressed with the power-packed presentation by Dr. John, highlighting the advantages of remote refraction or telerefraction, you call it, over conventional refraction during these COVID days. Both of you have done extremely well. And as a judge, I find it difficult to judge the debate, and it's really difficult. But going to the scientific content, I think we should take a middle path. We have to accept that fact that a lot of patients, whether we like it or not, are using web for refraction and dispensing glasses and contact lens. Now, we should not have a negative attitude and towards these newer trends, and we must use caution in dismissing new technologies like telerefraction. Because, you know, telemedicine for fundus photography already has shown great potential for screening ROP and diabetic retinopathy. With the newer technology, you may be able to give an accurate prescription and dispense glasses, as John said. But mind you, an accurate prescription doesn't mean a comfortable glass. As ophthalmologists, our aim should be to dispense a comfortable spectacle rather than giving an accurate prescription of getting 6/6. No equipment can replace human-to-human interaction in subjective refraction, which is an integral part, and that is lacking in tele-refraction. Even if the patient do tele-shopping and gets spectacles, if it is uncomfortable to wear, finally they will come back to you for a solution. So you should master conventional refraction to counter-check and solve the problem. To conclude, I would say, don't go with the message that the future is all about tele-refraction and you need not learn and practice conventional refraction. In fact, there is already a trend among postgraduate students to neglect refraction during their PG course. Refraction is an art learned and expertized by years of experience. So I request all of you to master conventional refraction, even if tele-refraction picks up in a big way in future. Let me remind you that refraction is the bread and butter of a comprehensive general ophthalmology. Thank you.
Thank you, sir. That was a very good summarization of the debate. Let's wait for the result. We'll move on to the last debate. Can I have the slide, please? This session will be chaired by Dr. Philip Kurula, sir. Judged by the Dr. Philip Kurula, sir. This debate is the cost. If you're going to do a very difficult surgery, will you charge more? If it is not the other way, whether it is difficult or not, you should be compassionate and patient-friendly. I will not charge extra. And that is what Dr. Natasha is going to say. And Dr. Srini says he'll charge more for a difficult case. And let's see the debate. And this session is judged by Dr. Philip Kurula. Over to you, Natasha, the lion.
Shall I start?
Your time starts now.
Friends, Indians, fellow KSOS countrymen and women, lend me your ears. I come not to bury Dr. Srini in this debate, but to praise him. Let us take two scenarios. In the first one, a manual laborer comes with cataract, hard nucleus, pseudo-exfoliation, non-dilating pupil. The cataract surgeon examines him and thinks, difficult case. I will need more time and effort. I could easily do 2 cases at that time. After all, what am I working for? I have a family to take care of. I have done my training and fellowship from a premier institute and I'm good. Isn't that why this fellow has come to me? I'm going to charge more for this patient for all the extra time and effort. Next scenario, same patient, same diagnosis. Comes to another cataract surgeon and he thinks to himself, this was difficult and it's going to take more time and effort. But he's a manual laborer. He's out of work now. And I can always charge higher for those who choose premium lenses, for those who choose femtosecond, or for those who have insurance coverage. And difficult cases like these are only for a small percentage of my cataract surgery list. Let me do it at the usual cost. Now I ask you, ladies and gentlemen, which category does Dr. Srini, my worthy opponent, belong to? He is my bullish opponent. There is nothing I would like more than to throw him to the hyenas. But I know him from many years, and I know that he has done perhaps the highest number of cataract surgeries in North Kerala without charging an extra paisa for the hardness of the nucleus or the zonular integrity or presence of pseudo-exfoliation. And he, without any doubt, belongs to category number 2. I say this with conviction because the doctor in category 1 is uncaring, callous, and dishonorable, who goes against the very tenets of the Hippocratic oath he swore by, one who has a mercenary and business-like mentality in matters of human suffering. And Dr. Srini, we all know, is not like that. He is an honorable man. Let me ask you a question. How can you grade the difficulty of a surgery or procedure? We all know the difficulty of any case depends on the skill and experience of the operating surgeon. What is difficult for one doctor may be a piece of cake for Dr. Minu, or easier still for our famous Dr. Philip Kurula. So how does even one do this grading? Should we have cataract surgery packages graded as easy, mildly hard, moderately hard, and severely hard? And think of the consequences of charging more. These kind of difficult cases are prone to complications even in the best of hands. How will you face the patient if he has a PC rent or a nucleus drop and you need to call in your retinal surgeon? Will you pay him from the extra money that you have already charged the patient? As a retinal surgeon, I'm even more troubled by this concept for an ROP laser. Can I think, oh, this baby has zone 1 disease. I will need to laser more area and break my back. Let me charge this baby more. Do you think that is the right way to think? Or a patient with RD comes and I charge depending on how many tears he has or the grade of his PVR. My dear friends, I tell you, hand on heart, as a doctor, I will not and cannot think like that. To charge more according to case difficulty is not only uncaring and unethical, but highly dangerous as we cross that fine line between service and business. We as doctors are blessed that we can save those who are in misery, but we are also cursed that we have to earn a livelihood of someone's misery. But let us understand that and not lower ourselves to the level of fish market bargaining. So with these words, I appeal to you, do not believe my opponent Srini, whatever he may say supporting higher fees for more difficult cases. He is just saying that for the debate. He is not that kind of uncaring, callous and irrational doctor. He is not the kind of doctor one should never be. Let us all look inside ourselves and think who is right. Then I'm sure you will find the right answer inside. Thank you, ladies and gentlemen.
That is fantastic. That's a way to go about and debate. Praising the opponent in the opposite direction and then coming to that. Over to you, Srini. What do you have got to say about this? Your time starts now.
Morning. I would tell you the actual experience of my neurologist friend who goes as a visiting consultant for DBS at a corporate hospital in Cochin. He found a note on the table of the neurosurgery HOD. The note was from the man who is an MBA in his 20s. The note demanded explanation from one of the senior-most neurosurgeons in India as to why no income-generating procedure has been done on 4 cases admitted under him. This is what we have let ourselves be, menial workers. Our worth is now determined by administrators and insurance companies. When we post a patient for cataract surgery, the patient goes to the counselor and the counselor tells the patient that we have different cataract surgery packages. The package cost is different for different package because the intraocular lens used in them is different and they cost differently. But when we actually compare the difference in cost of the different packages, when you compare the intent lens package to eye-enhanced lens package, the cost difference for the patient is 26,000 here. But when you compare the actual cost of the lens, the cost difference for the lens is only 8,000. So what is happening here? We are actually selling the lenses at an exorbitant price to generate more income. We are not charging properly for the surgeon's surgical skills. We are not charging for the facilities that are provided. What we are doing is we are acting like intraocular lens salesmen. We are selling lens and making money. No value for the surgeon's surgical skill. What I believe is that the actual intraocular lens cost should be put in the patient bill. And even when you do that, you make as much profit as when you act as intraocular lens salesman and you put value for your surgical skill. And also, you should never say that cataract surgery is a simple procedure. It took me years of training to be a person who can do phacoemulsification regularly under 6 minutes. And for me also, some cases are challenging. You would say, you would agree with me that these cases are challenging because it was high risk of suboptimal results and complications and require greater skills. Why would I charge more for these cases? Because I possess the required higher surgical skill, and I have the confidence to tell the patient that it is a challenging surgery involving several risks. And I'm not worried that he might go to my competitor who might say that it's not challenging at all, because I know that I'm being truthful to the patient. I'm taking higher risk of complications. You have to put value to that. The surgery would take up 30 minutes or even more. I can do 3 or even more cases during that time. My time is expensive. I'm going to charge more for these challenging cases. With increased time, the fixed cost increases. The OT rent, the staff salary, the electricity, the wear and tear of machine and microscope, the anesthetic time, all these cost money. And I have to charge more for these cases. Obviously, more consumables are used and you have to charge more for that also. You would agree with me that these painters should charge more than these painters because this is a higher risk, higher skill involved procedure. So is not charging more for complicated cases showing compassion, being patient friendliness? Absolutely not. Because what is happening is that other patients are cross-subsidizing for these complicated cases. If we don't charge more for this from these patients, the extra expense involved will have to be borne by the other patients. My tariff for the challenging cases will be higher because I am truthful, I am confident, and I show compassion to all my patients. So all, be confident, be truthful, show compassion to all your patients. Thank you.
That was probably a recorded version of it. There were no points highlighted what Natasha said. Now you can get it back to the stream only by your rebuttal. So, Natasha, do you want to say something? Now, you start your rebuttal now.
Yes, I think my opponent has changed his color since I knew him. And now he has changed into category number 2. But we are not talking about consumables here. We are not talking about the lens price here. We are talking about charging for your skill. Yes, you did a lot of training for reaching here. All of us did. We all went through all this training to treat every single patient, to treat every single complication, just as you would treat when a patient pays higher. So the payment should not be equivalent to your skill. The same skill you have to use whenever you do a CAMP patient, you do a higher paying patient, you do a Technis multifocal, whatever it is, you have to use the same skill. And that is what these years of training was for, not for charging one person extra because you need to use some extra skill over there. That we should not stoop to the level of that. That is what I'm saying. And that may be one of the reasons why our doctor profession is now being, mauled in the media partly because of this business mentality. He talked about corporates. Yes, the corporates have bought this in, but that doesn't mean we should play along with it. We should tell them that we have sworn the Hippocratic Oath, that MBA fellow has not. And that should be our point when we talk to them. We should say, no, if this patient doesn't need a procedure, I will not do a procedure. And lens package, all that is a different thing. That is business. But your skill and whether you're going to charge for it, that was the question here. And for that, I still maintain the category 1 is the compassionate and the good doctor. And if you look inside in your heart and ask your conscience, we should be able to sleep at night that we have given the best care to every single patient that we have. That would be my point here. Thank you.
Thank you. That was very emotional. What really got to say for this?
Yeah, I'm even more emotional. You all know about that Dr. Anu, who actually had to commit suicide. He thought he was showing compassion for the patient by doing a highly risky surgery, almost free of cost. And what happened? You know what happened to him? He had to commit suicide. See, you have to see that there is no point in hiding the money that you're charging on another patient, or as I said, being an IOL salesman. See, if there is any procedure which requires higher skills, definitely you have. See, I been not in North Kerala, all over Kerala. Probably I'm the highest volume cataract surgeon, and a major portion of my patients are free patients. If this patient who is a manual laborer who comes to me for surgery, and if he doesn't have money, I will do it free of charge for him. See, but if there is a case, I mean, if a person can afford, I mean, if he has a problem that has to be tackled, you have to tell that there is a problem and this requires more effort, and I'm going to charge more for this. As I said, even if he goes to somebody else and takes the service, I'm not bothered. I'm not bothered at all. See, let him get it done. I'm going to be truthful, and I'm confident to tell that it is a tough case. See, you take the case of veterinary surgeons. They never had the courage to charge for the macula hole and all previously. Once they develop the confidence that they're going to give good results for macula hole surgery, the surgery rates have gone to 60,000 and all. It's not business. It's not business at all. It's not being mean. It's being truthful to yourself. You don't have to let the MBA people tell that there is no value for you. If you're going to sell the IOL and make money, not at all. Be truthful, man. Be truthful. See, as I said, I would do it free of charge for the person who can't afford. But a person who can afford a normal package, I will definitely tell him this is fair. Okay, thank you.
Say what Dr. Srini wants to say is there should be a dynamic pricing for just like flight tickets. But let me ask one question. Will you charge less for a person with a very soft cataract?
Exactly. I knew that you're going to
below the normal charge. Below the normal.
Exactly. That's exactly. I knew that. That's why I put a slide in this. There is no trivializing this thing. Any surgery carries its own risk. I mean, personally, I'm asking you: is a soft cataract guarantee that you won't have a complication? No. There is a routine surgery. that routine surgery, you charge the normal case. But these are, I'm sure that you are going to agree that pseudoexpiration, subluxation are all different matter. Definitely this question was expected, and that is why I kept that there. By telling that cataract surgery is simple, you are trivializing your work. Don't do that, please.
Okay, we'll end with that. We'll go to the judge, Dr. Phillips, sir. Your opinion, sir.
Poll first, sir. Poll.
Audience poll. Sorry, we'll go to the poll. Audience poll for debate number 7. Very hot debate it was. Sir, Phillips, sir, are you there?
Yeah, I'm here. I'm audible.
Yes, sir.
I'm audible.
Yes, sir.
Both of you, Natasha and Srini, you did very well. I know it's an extremely difficult situation, and every day we face it. Very relevant, and I appreciate the organizers for including this the topic. Both of you did very well. It's very difficult to say who did better, but. The thing is, see, one problem in India, especially Malayalis, they think, well, cataract, it's a simple surgery and anybody can do it. And then we struggle and do a very complicated case, and the patient gets only 6/18 vision, and you're very happy because you thought that you would get only 2-meter vision. And the patient complains that I got only this much. And what do? You feel, then you feel happy, you charged him better, at least he paid for it. You know, that kind of thing, situation comes every day. But on the other hand, we have a responsibility to do the best for every patient, irrespective of the fact that they have, they are unthankful, they are thankless, and they don't appreciate the tension and the difficulty and all the training that you went through to do this surgery. So this is a very, very difficult situation every day. But every day, on an individual basis, we need to make a decision. That's what we wanted to say.
Thank you very much, sir, for summarizing that. That was the most emotional debate we had today. And everything went on well, and none of the debaters had any negative points in it.